Wednesday, the 19th of November 2025. My name is Steve Robinson. I'm the ward member for Litchett and Upton on the east of the county, also cabinet member for adult social care and lead for communities for all. Welcome everybody to what is possibly one of the coldest rooms in the building. I left my coat upstairs, and if I disappear halfway through the meeting, it will be still and over a radiator somewhere. Shall we just go around the room in the traditional way? First, for the people who are in the room, just introduce who we are and why we're here. And then once we've done that, if you could just announce yourselves at the start of every paper, and then once we've done that, we can let it go, because if people don't catch on by then, they can look back on how it goes. Shall we start off? Jill, do you want to start off?
I'm Jill Taylor, Councillor Jill Taylor. I'm the portfolio holder for Housing and Health, and I'm a Chippewa councillor.
I'm Don Rodford, Chair of Dorset Community Action.
Hi everybody, I'm Sarah Howard, Deputy Director of Place, NHS Dorset, and the local coach, I keep getting this wrong every time, the local coach for the National Neighbourhood Health Implementation Programme.
Good afternoon, I'm Rachel Partridge, I'm Deputy Director of Public Health and Prevention at Dorset Council.
And I'm Jane Horn, I'm the Consultant in Public Health and Prevention in Dorset Council, and also Clinical Lead for Health Inequalities for Dorset ICB.
I'm George, I'm de Clark to the Health and Wellbeing Board.
You met me.
Hi, I'm Jonathan Price, I'm the Exec Director for Adults, Health and Housing.
Hi, Sam Paul, Corporate Director for Commissioning and Improvement in Adults and Housing at Dorset Council.
Hi, I'm Sarah Sewell. I'm Head of Service for Older People's Commissioning at Dorset Council. I'm here for 2 items for Future Care and for the Better Care Fund.
Good afternoon, everyone. I'm Sian Walker McAllister, and I'm the Independent Chair of the Dorset Safeguarding Adults Board.
I am Paula Bennett. I'm Programme Director for Dorset Voluntary and Community Sector Assembly.
Hello, I'm Jen Fennell. I'm the Corporate Director for Education and Learning.
George, can you just read out who we have online?
Online we have Councillor Chris Kippax, Councillor Claire Sutton, Councillor Sally Holland, Louise Bate from Health Watch, and Claire Phillips from Dorset Police.
Welcome to everybody. Apologies have been received from
Paul Dempsey, Sam Crow, Jan Bretton, Simone Yule, Margaret Guy, and Mark House.
Oh, thank you. We've missed them dearly. We are at the stage where we need to appoint a vice chair. Very, very pleased that Sarah has agreed to have her arm twisted in this, but we are looking for a proposal, which I am happy to do. Seconded by Rachel. Everybody in favour?
Any other nominations?
Any other nominations? Sorry, the tumbleweed moment. Let's do by show of hands and acclamation. Then. Everyone. Unanimously appointed. Thank you very much indeed. Welcome.
Thank you very much.
I would hand over to you. The minutes of the last meeting are available. Can we all agree those as a correct record? Anybody have any difference of opinion? Then they are accepted, which I'll sign at the end of the meeting. Prompts me. Any declarations of interest on any of the subjects that we're going to be talking about today? I'm not aware of any. But if now, forever, speak up, forever hold your peace. There is no questions from the public and no questions from councillors and no urgent items today. Which brings me nearly to the end of page 1 of the agenda, which is always an exciting place, and then you see the rest of the agenda. Work programme, we note going forward, this is always subject to some degree of change. At the end of this meeting, we're going to move into a strategy discussion in a closed session, so we'll be looking at that. So that might have some impact on the work programme, but where we are at the moment, that's what we have. Claire has her hand up. Hi, Claire.
Hi, everyone. Yeah, Councillor Claire Sutton, Cabinet Member, Children's Services. Looking at the work programme, Steve, it doesn't seem to be a lot about children on there, and I don't know if that's something we should be concerned about, but I think it's something that we should be aware of and consider. I was thinking particularly perhaps in the CAMS domain, but just something for us to bear in mind going forward, please. Thanks.
I'd be very open to look at that. I think community mental health would be, children's mental health particularly, would be very much on our agenda as we work as a networks group. So I'd be very, very happy to take that. And indeed, if others have other issues they will want to put forward, my concern is that this doesn't just become, this is what the council is doing and everyone just turns up to listen. It needs to be very much what we do collectively within communities. So we'll be very, very open to other thoughts, comments and inspired thoughts after the meeting. Thank you. Thanks, Claire. Which brings us on to Sarah, the Future Care Programme update.
I've just got some slides to share. So good afternoon, everybody. I'm Sarah Sewell. I'm Head of Service for Older People's Commissioning at Dorset Council in the Adults and Housing Directorate, but I've been seconded onto the Future Care Programme as one of the Dorset leads. I'm on the home-based intermediate care work stream. So I've got a presentation just to take you through today in relation to the report. And you'll recall that at the last meeting, my colleague Sue and I provided a bit of an update around the kind of work that we've done so far. But thought a quick reminder about kind of what future care is and where we've got to would help just to kind of get into the paper that we brought today. So the Future Care Programme's an ambitious programme to transform urgent and emergency care and intermediate care pathways across Dorset, and we've got a target attached to the programme of getting that work done by 2027. It's a partnership programme that's a large scale programme, so lots of partners I've listed at the bottom of that slide there, all working together to transform those pathways. So the NHS team, social care staff and the voluntary and community partners. So we're working together to create a more integrated, person-centred system of high quality care that's responsive, reliable and safe. We're bringing today an update in terms of the mid-programme review. So we've reached this kind of key milestone within the programme and are keen to share that with you today. Important to note that we've come a long way in the programme so far. I'll take you through that in just a moment. We've got some areas that we're really keen to kind of highlight our achievements on. We have also got a bit more work to do as we kind of press forward. You'll see as we work through, the nature of the work streams that we have means that we're working at different paces and are at different stages in those work streams. So we're flexing our approach as we go through, and as we understand how our improvements are making a difference, where we've got more room to improve. And one part of the work that we're doing is really around data, so understanding where we're at by using that data that we've got to inform our actions and help with our decision making. So the purpose of our report today is, as I said, to share the conclusions of the mid-programme review, which will provide you with an update on our progress, give you assurance on the benefits that we've already achieved, and outline those corrective actions where we identified that we've got some improvements to make. I'm also really keen to highlight the positive impact the programme's made to Dorset residents. I've included a couple of case studies at the end just to highlight that, but also highlight within the mid-programme report, you can see the ways of working for colleagues in those urgent and emergency care pathways and in intermediate care is another area of improvement. So just as another sort of quick recap, so we launched the programme in 2025, and that was following an extensive diagnostic exercise. We have 3 strategic aims around improving hospital discharge, reducing long-term care needs and enhancing recovery at home. We're arranged in 4 delivery work streams: alternative to admissions, transfers of care, home-based intermediate care and bed-based intermediate care. And each of those work streams is led by one of our system partner executives. So we've got that real system partnership approach to how we're working through our programme. So the key achievements that we've outlined within the report and the positive impact that we've made so far, I've just shared here on this slide. So substantial operational benefits have been delivered across the system. We're projecting £12.87 million worth of operational benefits against a target of just over £12.5 million. In our bed-based intermediate care work stream, we've already made a 30% reduction in the long-term care placements for people after a stay in bed-based intermediate care. So less people are going on to long-term care after a stay in those bed-based settings. And also the amount of time that they're supported in those bed-based settings is reducing. So already we've reduced the length of stay by 5 days. So it was around 38 days. We reduced that down to 33. In the same day emergency care work stream, 55 more people are being seen each week. So that's providing alternative approaches to support someone to address their needs rather than an admission into acute hospital. So you can see there that there's significant improvements to the quality of people's care experience that's being made across those work streams. We have also identified in our mid-year review work some areas that we need to improve our focus on, or increase our focus on, I should say. The hospital discharge delays, we haven't managed to get those delays down to a level that we think that we're targeting. So that's the time for which a person is waiting to be discharged when they're declared medically fit to leave the hospital setting. So at the point that the report was written in early October, the average wait was around 9.6 days. Our target is 8 days. So we've got some more work to do in that space. The work in our transfer of care work stream and embedding the transfer of care hubs, that has taken slightly longer to embed than we hoped. We have made good progress already since the report was written at the beginning of October, and we've got improved work focusing in on improving how multi-agency teams work together. Just wanted to highlight as well, just to kind of bring that to life, because quite often when we talk about transfers of care and the ways that we work, it's probably not always clear if you're not working in those settings. So I just wanted to highlight on page 4 of the appendix, there's some examples of the different ways of working within the transfer of care hubs from staff. There's some quotes in there which sort of bring it to life a little bit more, which I thought might just be of interest to the committee. Another area of challenge just to flag is we've had some capacity challenges within our home-based intermediate care work stream. So we've had some reablement staffing shortages that particularly impacted flow through the pathway during September. However, really hard work from the reablement providers has addressed that, and we're getting back to where we need to be in that space. So just in terms of a summary for those areas of improvement, and we have already got actions in place that are starting to address and improve that position. So just to give you a slightly bit more information in terms of how that performance is improving. From those areas of focus, we're reducing the number of people that are waiting in hospital. So we can see from our dashboards, and I've got a screenshot to show you in just a moment, the delays at Dorset County Hospital are already reducing, and we've got planning and positive actions in place to support the acute hospitals over in the east of Dorset. We have increased our focus on system flow and faster decision making. I've got some evidence again to show you in just a moment, but we're increasing the percentage of people that are getting home. We've taken positive steps and have made improvements there. And we've made some key appointments to create a new flow team. So we've got flow leads in place now who are responsible for overseeing the discharges into home-based and bed-based work streams, and for managing, really importantly, managing those caseloads to make sure that people are being supported through those pathways, and that we make quick and timely decisions for individuals in those pathways. So just wanted to kind of give a little bit of detail in terms of the work that we've done from a Dorset Council perspective and for Dorset Council residents. So this is a snapshot of one of the dashboards. So a key area of improvement and focus for the programme has been around visibility of our system performance data. This dashboard shows you our discharge delays over on the left, and the number of people or the percentage of people that we're managing to get home through pathway 1 on the right. So following back at the beginning of October, following the programme review, Dorset Council prioritised some support into those areas of focus that I've mentioned. We can already see from this dashboard, it's just showing you the evidence that we've reduced the length of stay for people waiting to be discharged by 4 days. So we're currently, for Dorset Council area, currently at 8 days. And we have increased the percentage of people getting home with recovery focused support by 5%. So those differences and that focus that we've made has made a difference already. So just one final slide, just wanted to share with you a couple of case studies of the positive impact that the work's having for Dorset residents. It's mentioned in a bit more detail within the report, but the first example is of a gentleman that we've called Lewis. So he was discharged home with home-based intermediate care. We have a reablement app that is used by 2 of our reablement providers, And the greater attention through the app to goal-focused reablement approach enabled Lewis to have a swifter regaining of independence with personal care. That enabled his care to be stepped down more quickly, which freed up those resources for the next person that was waiting for that support. And then there's another example, a case study about Melvin, who was discharged and supported at one of our community hospitals. At the point he was discharged from the acute setting, he was unable to stand or walk following a long illness, and he had lost a significant amount of weight. However, with a positive recovery routine and with regular physio, within 3 weeks, Melvin could walk with a Zimmer frame. Dietitians helped him to regain weight, and with equipment, he managed to get back home to his wife. And I just wanted to include on there the feedback from Melvin. He described the staff who worked with him at the community hospital as fabulous, kind, caring and competent. So just to wrap back round to the recommendation, asking the Health and Wellbeing Board to please recognise the progress that the programme continues to make in respect of improved outcomes to people and delivery of the financial benefits to the Dorset ICS. But also just to recognise we've got a bit more work to do in reducing the average length of stay for people in hospital who are ready to leave with support.
Fantastic, thank you, Sarah. Any thoughts or comments? One thing that struck me, and I've just loved every aspect of this programme because it touches people's lives. Sometimes we get to the statistics and the percentages and the organisational benefits, and we miss out on how much it benefits people. And I think your final comment was actually the personal touch, as it were. Can I ask a question about integration within the community? That we are getting better, I think, at stopping people needing to go into hospital, although there's still quite a way to go on that. And we're getting better at people being discharged from hospital into care and to some degree back into their houses. But what would the next stages be? How do we use local services more, local charities more, local communities, local neighbourhoods more to increase that impact? I didn't prepare you in advance of this one.
I was going to say the programme manager, director Dylan Champion.
Oh, Dylan. Hi, good afternoon.
Hi everybody. And I think that's a really good question, and I think the answer to the question is we're at the start of that journey, where we're beginning to deliver more sort of integration within the community. Is first of all with that work around sort of admission avoidance and working more closely with volunteering community and other organisations to help people leave emergency departments without being admitted to hospital and building the relationships there. But also as we develop the transfer of care hubs, it's what's really key is that they integrate much better at place and with local organisations. And the truth with that is we're at the beginning of that journey, and we've started to make the relationships, we've started to make the connections, but there is a lot more to be done.
Thank you. I think that there's some media this morning nationally about how the NHS was not achieving targets, and this goes completely contrary to that narrative that actually when we concentrate on the individuals, it makes it work. Louise and then Sarah.
Thanks, Steve. Thanks, that was a really good update. I was wondering where hospital at home kind of fits in with all of this. We at Healthwatch, we recently did some work where we interviewed carers of people who are looking after someone who gets hospital at home, or another term that's sometimes used in the system is virtual wards. So keeping people out of hospital by giving them hospital-based services, but in their own home. And carers told us overwhelmingly they felt really positive about the service. I think it still had some kind of impacts on their kind of emotional well-being and stress. We made some recommendations to improve some of that service, but I was just wondering how the increase in kind of people receiving hospital at home or virtual wards will impact on the future care service of keeping people out of hospital, basically.
So
yeah, I suppose the virtual ward is a key. The virtual ward offer is a key sort of pathway for to support people to get home. So in terms of where that sits, it's a key function that the transfers of care teams will be looking to when they're working together to develop solutions for people, and a key way for us to prevent admission. So we have in terms of the focus on that, it's not a specific work stream that we have, but it's one of the services that we're working to and working out how we make best use of those services. Has that covered your?
Yeah, thanks, Sarah.
Well, Sarah.
Thank you. I just wanted to bring in here the conversations that are taking place around the neighbourhood health programme, because there's a real synergy between the future care programme and the neighbourhood health programme. And how I see it is kind of as two swim lanes, if you like, which at the moment there is a kind of false barrier in between, but they are coming together. And the neighbourhood health programme is very much about GPs, other primary care staff, together with community staff coming together to focus predominantly in the first instance on people with long-term conditions and rising risk of hospital admission. So we're almost talking about the same cohort of the population, but not quite. And the idea of the neighbourhood health programme is that we start to kind of move down the kind of population triangle of need, if you like, and really embrace the voluntary sector and communities to, enable people to live well and not to deteriorate and need those services, if at all possible.
One of the ambitions within the NHS 10-year plan is virtual hospitals. Building on what Louise talked before about virtual wards, is there the potential that we could bring this together into some concept of whatever a virtual hospital is? Would that be a vision that we would have for the future?
I would say that the concept of virtual hospitals, it's more kind of focused on neighbourhood hubs, and it is about bringing services from the acute hospital closer to home in the community. So the more of that we can do, and the more outpatient kind of type clinics we can offer closer to home and in the community, is the direction that the NHS 10-year plan is taking us.
Very much along that sort of line. Bill, did you want to say something?
I will on this one. I'm just wondering about capacity within the NHS for the virtual wards. Have we got sufficient capacity? Because I'm thinking the more people we get out, the better. The more people we stop going into hospital, the better. But we can't do that unless we've got capacity within the hospital at home, ward at home, whatever you want to call it, to actually support the people there. Just comes from personal experience. When I've been on that scheme, and there was a question whether they've got capacity to get me out and get me home, or whether I'd be better just staying in hospital. And it's just a capacity question.
I think there's always a really fine line for all of our discharge services is capacity. So I think we're still sort of working through what the future state of our services in those discharge spaces and at the front door to prevent admissions. We're still working a lot of that through. So I think we're not entirely. I don't have exact details for you right now, but that's the areas that we need to kind of work through as we start to the next stage of the programme. Or linked to the programme will be about those services that we need and how do we best arrange them to get the pathways working truly effectively for everybody.
Okay, because that seems to me a good way to sort the discharge issues out.
Yeah, it's a key service that's making a real difference to people. Yeah, thank you.
Yeah, Don Nordberg again. Notwithstanding Steve's warning about relying too much on the figures, I've looked at the figures in your framework submission and said, what's the problem with discharge? Because the report you had all the numbers that were basically around the target, because it was a target on a percentage, not on days. And I wonder, given the discrepancy that you talked about between those two figures, whether there's something special to look at about people who are really seriously over the number of days target, because the median is obviously very close to what you're expecting to get to. It just seemed to me there might be a specific problem to look at that's related to the people who are really being delayed. because that's probably bursting the seams of it. Still quite a big gap between 9.5 days and the 8-day target.
Are we just going for the low-hanging fruit?
Yeah.
And
And those people are the people who are probably going to achieve the most benefit by getting back home. And if there's a way of separating that, just as an idea. And I think as a report going in, if I were on the receiving end of this report, I would raise the same question. What's wrong? You say that we're below target, but the numbers all look like they're on target. So what's wrong?
I think this stage, because it's a mid program first year review, so sustaining those numbers is the issue. If you can sustain those numbers, you achieve all of the outcomes, but it's quite early days. So it's a 3-year program with 6 months in. There's a lot more to do, and there's a lot more for the different work streams to come in to align to sustain that. But Dylan might want to add to that. So, did you want to come in, Dylan?
Yeah, very, very briefly, and it's a really good question. And as John has said already, the sort of initial focus of the programme so far has been on helping and supporting those people on what we call sort of core pathways to get home more quickly. So those people that where a community hospital bed is the right thing, or a reablement package is the right thing. But as we've got more into the analysis, what we've found is that across Dorset, somewhere between 15 and 25% of the people waiting in hospital, that's very that sort of conventional community hospital bed or the reablement offer isn't quite right for those people. And so there is a need to identify those gaps and commission things slightly differently, because they're the people that unfortunately spend slightly longer in hospital than those people with less complex needs. And so the focus so far has been on improving that reablement pathway, reducing the length of stay in community hospitals. But as we get more into the sort of detail of the analysis, it's becoming clearer what the needs of those people that are stuck for longer periods of time are. And that will be the sort of increased focus as we get into the sort of next phase of the programme and next year. But you're right to identify, because it's quite a substantial cohort of people that are currently waiting a bit longer than others.
Thanks, Dylan. I think if I could just add, these type of programs, they build over time. So as you fix one problem, next problem arises and you can see it clearly, and then you fix that. So that's very much the process. I think as the updates come here more regularly, you'll start to see some of those numbers change. But the first bits, you always identify where the big blocks are. You do fix some of the smaller problems early on.
My question was to anticipate that next step, because if it is that there's a cohort of people who are being severely delayed, that might be the place to point your attention.
Yeah, I'm just sort of building on what you've just said and thinking about it. If it's a problem with housing as a discharge, then there's probably going to be quite a long delay. So if you've got somebody in hospital, say, who's a rough sleeper, who we haven't got anywhere to discharge them to, is that sort of individual slowing the figures? And if so, how can Dorset Council be very much involved? I'm the housing portfolio holder, and I'm very keen that we have properties that we may be able to use to assist with discharge from hospital.
I think just to give you assurance, so where we do have individuals who have long lengths of stay, there is operational processes, and people working on the ground will know who those people are, and they will be working with those people proactively. It's just it will take longer to get the right solutions to enable people to leave hospital. There's been lots of focus on housing issues. We haven't got all of the answers right yet. People still are waiting longer than is necessary, or maybe that they should do. I think we're working together with housing colleagues to bring them into the conversations as early as we can. So part of that transfer of care work is to identify what somebody needs to help them leave hospital earlier in the process, so that we can get ahead of some of that and start to bring those delays down. But it is causing delays, but it's getting.
I met with a number of charities a few months ago, and it was highlighted that just because someone's in hospital with a broken leg doesn't mean that's their only problem. That just means that's an initial, immediate presenting one. There can be longer term issues, such as dementia, which involves a whole load of additional concerns, issues around learning disability, again, which are issues that require more intensive interventions, issues around safeguarding. All of which are issues that need to be brought into the consideration, that although the leg may be fixed, there are a lot more reasons why we need to make a really careful consideration about sending someone back home. So a lot of these are not just held back because we can't discharge them, but they're held back because we shouldn't discharge them. Yeah, and I think there is some work to be done identifying what those particular streams are. But the work that's in bringing this section to a close, in order to bring focus on the good work that has gone on, this has made an enormous impact, financially, culturally, but also in terms of individuals. And so, I would encourage us all to endorse the report, to note it, and to look forward to the next iteration. It's remarkable, I think, that Dorset, in this day and age, when there are so many pressures on NHS, so many pressures on communities, to have such a really good, shining beacon of good practice going on. Thank you very much. In an effort to change the agenda, and bearing in mind that flu shots need to be had shortly, Sally, sharing too much publicly, Sally. I do apologise. Can we move on to the Safeguarding Adults Board report?
Thank you very much, Chair. So I'm Sian Walker-McAllister, the Independent Chair of the Safeguarding Adults Board, and I've been chairing the Dorset Board now for some 4.5 years. I also jointly chair the BCP Safeguarding Adults Board, and whilst we have all our meetings together, share subgroups, strategy, policy and ways of working together, we actually have retained 2 separate boards so that we are able to address place-based issues if we need to. So they're constituted separately. So this year and last year, the annual report, which is before you today, only has the Dorset data. When we used to do a joint annual report, we got down alleyways of conversation about comparing BCP to Dorset when they don't really compare. So we decided to do separate reports. It's really an efficient way of working, meeting together, because most of our strategic statutory partners, well, all of them, work pan-Dorset. So in Safeguarding Adults, that's the NHS and the police and adult social care, the 3 statutory partners. And we also work with a number of other partner agencies in the both the public sector and voluntary and community sector. Page 5, sorry, not slide 5, because I'm not showing a slideshow. Page 5 of the annual report has got the logos of all the partners that we work with. And I would really like to commend some of the work we've done over the year in question, which is up to March 2025. So it's the previous financial year. I'd like to commend some of the work with prisons and probation that we've undertaken, which is really important. Adult social care has a statutory duty to work with prisons on identifying prisoners' care and support needs. And as such, we have a statutory duty to work on safeguarding. And because I believe that as a statutory board, we also need to work in strong, close partnership with the Children's Safeguarding Partnership and the Community Safety Partnership. In doing the work we've done on working with prisons and probation, we've done a lot of community safety preventative work and linked in prisons and probation staff with housing, with adult social care, with a number of other agencies through the aegis of the board to be talking to one another, escalating issues well in advance rather than having to deal with problems as they come up at the last minute. So the annual report then, the statutory duty of the board rather is to have a strategic plan, to report on it once a year in the annual report, to present that annual report to the Health and Wellbeing Board, and before we do all of that, to discuss our annual report with Health Watch. And Louise Bate, as a member of our board, has a copy of the annual report before it comes to board and before we agree to publish, and to check out that she and her committee are happy with the issues that we raise, and that they can also scrutinise us if there's any issues that come up under Health Watch that they feel that we need to be picking up. So this report, as you will have seen on reading it, is really co-produced. It contains information from all our partners from their perspective around the challenges and the plans around safeguarding. I would also say that, as well as having, we have four subgroups, I beg your pardon, to the board. So we have the Safeguarding Adult Review subgroup, and that's the subgroup that makes decisions recommended to the board on the commissioning of safeguarding adult reviews when somebody has died in the area where their death might have been prevented had two or more agencies worked better together. Now, in this particular year, there were no safeguarding adult reviews or SARS in respect of Dorset. We had several for BCP, but there are currently safeguarding adult reviews ongoing that will be published in next year's annual report. One piece of work, we've been working with public health, for example, on suicide clusters, which is a duty of public health. And what I agreed with the outgoing and now Dorset's new Director of Public Health is to provide the governance under the aegis of the Safeguarding Adult Board around suicide clusters, so that if there are any, that we can work together from a safeguarding perspective on those. We identified three cases where we thought it might be a cluster. This wasn't agreed, and we're now proceeding with a safeguarding adult review in respect of those individuals. In this year, we also set up a very strong protocol with His Majesty's Coroner, was Her Majesty's at the time, and we now mutually inform one another whether there's an inquest or whether we're considering a safeguarding adult review. And that's so we work efficiently together, so we're not dual running issues, and we can consider whether safeguarding adult review needs to take precedence before an inquest or vice versa. And we do that with all our work. Similarly, with mental health homicide reviews, we're doing some work across the Southwest region to ensure we have a protocol and a memorandum of understanding the way we work. So Safeguarding Adult Review subgroup is one of them. One of the groups is a Quality Assurance subgroup, which is chaired by Tonya Dawson-Sheehan, who's one of Dorset Adult Social Care's members of commissioning staff. And we receive the data from partners, do a lot of audit of data, and consider whether there needs to be a deep dive or a particular issue investigated because there's a particular trend. One of those trends in the last year was looking at making the application of making safeguarding personal. Essentially, what that means is that we consult with the people who are receiving a safeguarding intervention to ensure and continue to ensure throughout our way of working with them that they are determining with us the best outcomes for them in terms of the learning and good practice and being safe going forward. And that's really, really important. I often talk, I was at our community engagement subgroup conference earlier on today, and I often talk about an invisible tattoo on my arm. Something I use to sort of say, making safeguarding personal is always there, and I want that to be on your arm too, so that we consider the individual and nothing about them without them through every piece of work we do, whether it be working with partners at the front line and their practice through to the strategic work of the board. And in the strategic work of the board, we have a personal safeguarding story come to every board meeting so that the whole board have the opportunity to reflect within their own and other organisations. And it really ensures that we are absolutely clear while we're sitting around the table in a board meeting. It's about safeguarding individuals, vulnerable individuals who, because of their care and support needs, are not able to protect themselves from abuse, from neglect, or from harm. There's one other subgroup that we established during this year, and it was the Mental Capacity Act and Deprivation of Liberty Safeguard subgroup. And we established that group because we identified trends through data and through safeguarding adult reviews that the application of the Mental Capacity Act wasn't always as it should be. So we've now got a gathering of professionals who work in that arena across Dorset and BCP. And one of the really positive pieces of work that comes out of that, and links to the last item actually around hospital discharge, is a memorandum of understanding that's been agreed on ensuring that professionals apply the law so that nobody's being illegally detained in hospital, and that there are escalation protocols if it's difficult to discharge somebody because there may not be the right place for them to go to, but where it would technically be illegal to detain them. So it's really important that we have that governance piece over deprivation of liberty, or DOLS, that will change under the new legislation, and the Mental Capacity Act. Our strategy is divided into 3 sections on prevention, accountability and partnership. And there's a section in the report which sets out all the work that we've been doing this year. I've already highlighted the work with prisons and probation. We work with housing providers and safeguarding, and we have a community of interest group that sits outside of the board formal governance structure, but which we support, and where I attend an event once a year to look at the issues that housing providers have around safeguarding, and we believe that through that piece of work and through colleagues in both Dorset and BCP, we have much better relationships around understanding safeguarding and the need to intervene at the appropriate stage. I meet annually with the Chief Executive, and I just met with your new Chief Executive in the last month. And I meet every 6 weeks with Jonathan Price to discuss issues that may be coming up on the board, or for him to raise issues with me. And as such, that gives me the assurance that every partner within Dorset is doing what they should be in relation to delivering effective safeguarding vulnerable adults in our community. And I say that I bring 48 years of experience as a social worker and a former director of adult social services myself, and a former elected member to that role. So I understand why it's so important that we hold everybody to account and have meetings, have a culture in our meetings where it's safe to challenge and to hold each other to account, and to raise issues both at meetings and outside meetings when appropriate, to make sure that we're doing the right thing. It's an absolute pleasure to chair this board and to work with partners across the voluntary community sector, the fire and rescue service, prisons, probation, housing, adult social care, community safety, and I could go on. And I present this report to you and hope that you will note it today, and believe that we've done everything that we can to provide you also with the assurance that we have the right governance for safeguarding in Dorset.
Thank you. Thoughts? One of the things that I'm particularly keen on is that safeguarding is owned within communities.
Absolutely.
And I think there's a big challenge, because safeguarding is seen often as the enemy. The social workers are seen as the enemy on EastEnders. And the challenge, I think, is how do we make safeguarding everyone's business, as you say? How do we educate, and how do we provide access points within the community for the stuff that we don't see?
And that chimes in my heart, really, because so I believe we should communicate, and we should not communicate with jargon. We should make reports simple and accessible, and I present this report to you as one which is readable and accessible and sets out very clearly what we do. And when I was asked a question at my interview 5 about just nearly 5 years ago, you know, what's important for you? And I would say that if I'm talking to somebody on a bus stop in Bridport, actually, and somebody says, what do you do? And I tell them I should be able to explain it in such a way that they can understand. And I want all professionals to explain safeguarding in a way that everybody understands. And I've just come from this meeting this morning where I stood up at the front in response to some questions and said, look, at the end of the day, we had a couple of one of the Dorset managers, safeguarding manager and a BCP one, and they were a bit technical, which was fine, you know, because that's their job. And they were talking about the various sections within the Care Act. And I said, look, at the end of the day, I sort of said to everyone, you don't need to know whether it's section 42.1, 42.2, 44 or 45 or whatever. Actually, what you need to know and understand is that if it doesn't feel right in here, if it doesn't look right, if it doesn't smell right, and you don't feel right about it, and you think somebody vulnerable who possibly has care and support needs support, then contact. And I said in safeguarding adults terms, it's very simple because adult social care is the lead for safeguarding. So contact. And where I have assurance, and it's in the data on this report, so you can see from the data that there's something like 7,200 and something, sorry, I haven't got it in front of me now, it's come off my screen, concerns that have been accepted, and then 10% of those, about 720, have gone on to safeguarding inquiry. I feel I've dug down into that because you could, if you didn't work in safeguarding, you'd think, well, that's not very good, is it? They only dealt with 700, they only dealt with 10% of cases. But actually, that is good because they provided me with assurance that actually of the remaining 90%, what's good about the fact they've come into safeguarding is we can pick them up and refer them on to other services. So I know that a certain percentage, I couldn't quote that off the top of my head, I could send it to you later if you wish, but a certain percentage will go on to receive Care Act, Section 9 Care Act assessments. A certain proportion will go on to receive a referral into a voluntary and community group that may receive funding from Dorset Council to provide a certain service in a certain community. A proportion might be dealing with a supported housing provider who's got a contract for delivering floating support into a specialist housing scheme. And it chimes with the other work that you've been considering today, because we need to make the support go in at the right time in the right place where the person doesn't feel institutionalized or social worked, if you will, and I say as a registered qualified social worker, into a service. I always give this example. My father was an assistant director of social services, and at the age of 90, when it was suggested to him after a hospital admission that he needed a social work assessment, social worker, you know, because he was a qualified social worker himself. But what he did accept was an OT coming in her green trousers and her white tunic to be able to go in and say, well, Mr. Walker, you need this, this, and this. And I think, you know, what do you think? And actually he accepted that. And we call that in safeguarding, we call it contextualized safeguarding. It's about understanding the context within which people live. And we need to apply, and I have assurance that Dorset Council applies contextual safeguarding with the queries that come in through the front door. And I know that there's 729 that have gone on to safeguarding inquiries. There's a really well-rounded team around the person, analysis and understanding of the needs of that person and what needs to go in place to make them safe. At the end of the day, am I assured that we're 100% of the time going to make everyone safe? No, we can't be assured of that. We are human beings and we take risk. I probably drink more glasses of wine than I should, you know, and I've got the capacity to take that risk, understanding that decision. I mention it because it's just an easy, simple example. And it's an example I would talk if I was talking to somebody on the bus stop. So I feel very assured that the work that goes on within Dorset is good. I feel more assured because my work's strategic. I only work 20 days a year for Dorset, but I deep dive down and I have relationships with many people at senior level that I go and I talk and I go through things with that gives me that assurance, as well as the assurance from partners who work with Dorset Council and its services, who tell me that, you know, this has worked, or maybe that hasn't on occasions. And if it hasn't, then we raise it and we deal with it appropriately.
Thank you. Having sat in on a number of meetings, none of which are short.
No.
But all of
Only
which
4 times a year.
but all of which are incredibly detailed, incredibly forensic. I have been so impressed by the quality of the contributors as well as the leadership of this particular piece of work. But as you say, there's always more to do. And I think just being good is not good enough when there's people that might need our help, might need your help. So I look forward to, in the future, developing this conversation more about, as you say, about how we make safeguarding everyone's business.
Thank
And we reach out to them.
We did present, as you know, to scrutiny on Monday, and I met with some of your councillor scrutineers the previous week as well to go through the report in a bit more detail. So I'm finding lots of different ways to make sure we socialise this report in as many places as we can.
No.
Yeah, Don Nordberg again. Thank you. That was really interesting. I'm going to declare another interest here. I chair the board of a large social care provider for people with learning disabilities and mental health problems, but based in Bristol, not here. Doesn't touch here at all.
Brunel?
Your numbers on safeguarding referrals, 10%, struck me as completely ordinary. We have, at the other place, we have probably 1% of safeguarding referrals end up going into cases. I thought, okay, thank you. We're probably doing a pretty good job. Now, that leads on to the question I wanted to ask you with respect to Dorset. I think it's probably a really different thing dealing with the sort of safeguarding cases that you look at in the rural part of Dorset compared with what you've got in the conurbation in Christchurch. Is there anything different about how you work, say, with community organizations when the communities are scattered as opposed to when they're in densely populated areas close together?
So I think if I answer your question from my perspective as a social worker, and you know, I've worked in rural areas, and I started the first 20 years of my career was in London Borough of Hackney, so I kind of have very different perspectives. And in a rural area, you have to recognise isolation. You have to recognise that if there's gossip or issues going around in a village, they will affect everything going on in that village, and they will impact on safeguarding as well. You recognise that people will know more in a rural area usually what's going on with their neighbours than they might do in another area. And you just have to be aware. You have to, when you're horizon scanning, in terms of kind of having your analytical brain working with people, you have to recognise that there's very different issues. I remember working in Cornwall and the Isles of Scilly, and I used to be the adult social care advisor for the Isles of Scilly from when I worked in Wiltshire Council. And you know, you deliver domiciliary care according to tide timetables, and you just have to have a different perspective. And I think it's about sort of taking your professional hat off, where you're saying, actually, this is a process of doing something. And it will be particularly an issue more so for commissioners, I think, in terms of understanding rurality and understanding what needs to be in place, but also understanding the positives of rurality as well. So, you know, in years gone by when we had lots of day centres, I mean, we don't have those anymore. I think that's quite a good thing, actually, because we're not institutionalising people. But if you've got the local village pub that can provide lunches, you know, with a bit of stimulating grant for older or disabled or lonely people within the community, that's perhaps a good investment of money from a prevention perspective. In the way that we might deal with prevention for delayed discharges of care and prevention, looking at the colleague who's left the room who's talking about out of my head, virtual wards and virtual hospitals. sometimes spending money at that end of things makes a real difference for prevention. And safeguarding is all about prevention. I can chair a board to the end of my days and it will all run perfectly smoothly, but actually, and so what? What we really need to do is seek assurance on how are we preventing these things happening, and we have to have a different perspective to the town centre in Bournemouth than we have to in a small town of Sturminster Newton, for example.
My question, and I'm from Sturminster Newton.
Oh, right, okay. I didn't know that.
And I'm also an emeritus professor at Bournemouth University, so
you understand it well.
So what I was wondering was how you deal with intermediaries, with local community groups, with local charities to work in rural areas.
Okay.
Which would be the real difference there is how do you know who to work with?
So I've just come from a conference this morning at the Hamworthy Club in Poole, where we've been, Pan Dorset, voluntary and community sector, have been meeting and talking about safeguarding. And it's part of our strategy of communicate is to ensure that we spread the message out about safeguarding as far and wide as possible. We ensure that voluntary and community sector organisations understand and are trained at the appropriate level. You're not going to use sledgehammers to crack nuts, and that we establish a relationship with those organisations so that they get all the information they need and they know where to go to escalate with any concerns, and we through the aegis of the community engagement group, we have statutory partners as well as the voluntary and community sector working together. Now, as I said, we're a strategic board, so we're not going to do the work that Dorset Council does in other parts of its remit around the voluntary community sector outside of adult social care as well as within adult social care. But it's important, I think, that any chair of a safeguarding adult board is aware of what's going on in and amongst partners and reflects that in the same way, so that the voluntary and community sector are not getting three different messages from three different organisations. So we're singing from the same song sheet. We're very, very clear that safeguarding is everybody's business. And if somebody raises a safeguarding issue from within the voluntary and community sector, that they know, they talk to their line manager about it, not with all the people in their community and their little community group, and that it's then passported up through adult social care as appropriate.
One of the things that we want to do across Dorset as part of Communities for All is to encourage community conversations, so that whether it's in Weymouth or whether it's in Sturminster, local agencies will come together to be able to share concerns, and then so that things are not just left bottled in one particular area, but actually people have got an overall awareness, and that's something that we want to be working out. Again, through integrated neighbourhood teams, I would suggest as well would be a part of that, but schools, councillors, all interested parties that have roles within communities would be able to share information of that sort of thing. John, you wanted to come in? James. Oh, Jane.
Thank you very much. Hello, Sian, again. Saw you at scrutiny earlier this week. I just wanted to ask you a question about continuity of care, if I may, around young people, and those in particular young people who are 17, just turning 18, and that transition from children's into adults, and how effective and that we are here in Dorset at that, and I'm sure we are. I'm sure you're going to tell me we are, and how we avoid any of those young people sort of falling between some kind of gap.
Thank you. So there's been a huge amount of work in your Birth to Settled Adulthood programme within Dorset Council, and I've seen improvements in that planning, that transition planning for young people into adulthood in the 4.5 years I've been chair of the board here. So when I started, one of the pieces of work that I wanted to engage the board in was a position statement on transitional safeguarding that could be shared across the statutory boards. And we sought agreement from the Children's Safeguarding Partnership, which was Pan Dorset at the time, and the Community Safety Partnership to accept and acknowledge this position statement so that we were all working in the same way. And what's really important is that we ensure that the recognition of care and support needs within adult social care services might not be a disability, or it might not be somebody who is receiving a service. It might be that they had adverse childhood experiences and they're experiencing trauma, and the result of that trauma, there's an impact on their mental health, and as they emerge into adulthood, way past teenage years and into their early 20s. So we've done a lot of work around how we can all work together with younger people from the age of 14 onwards to prepare them for that transition, and how we work with staff who are delivering services on the front line to acknowledge what care and support needs actually are. And in some cases, they might not be visible. It might be about trauma that a person's experienced, and how we can then continue to support them through and into other appropriate services. We've done a lot of work with the universities. We had a safeguarding adult review, which happened when a student at Arts University Bournemouth took her own life about 3.5 years ago. And the result of that was that we have a group that sits underneath the aegis of the board, but isn't part of its formal governance structure, on higher and further education, adult safeguarding. We just met last week actually to talk about how we ensure that the universities are managing that complex issue around young adults with care and support needs who don't want their parents to know. And so what can the universities disclose, to get support for an adult? And we've done a lot of work around enabling the universities to understand that they can disclose information to adult safeguarding if it's in the best interest of preventing harm, neglect and abuse from happening. And we've done a lot of work around that and sharing learning about safeguarding adult reviews. There was also a Regulation 28 issued to the university following a coroner's inquest, and we've picked up on that as well, because there are similarities around young adults transitioning and burgeoning mental ill health needs, and how we all work together. At the end of the day, it's important, Jane, that we work together, we understand each other's remit, and we communicate well on all these issues. That's why having the position statement was important to me. And with the new setup, with the new separate safeguarding children partnerships for Dorset, we're starting some work again around that position statement to refresh it and reinforce it.
Encouraging, thank you. Just in bringing this to a close, John, do you have any?
Yeah, it was just really a big thank you for the work of this year. It's a great report, and I think there's lots of evidence of continuous improvement through the work of the board, and learning events in particular were fantastic this year. So just a big thank you.
Good. Thank you.
Sorry, Steve, I just had a quick question. You mentioned about the establishing of a hub looking at people with vulnerable adults reporting offences against them, and additional support being put in place. And I just wondered whether that hub would also include voluntary sector commitment, or if it was just police-based.
So that's not police-based. Safeguarding Adults Hub is provided within the council, and the voluntary and community sector, we just spent time this morning actually sharing with the voluntary and community sector groups across Pan Dorset about the hubs and who to contact. We've upgraded our website to have that information, and we work closely with the police, the statutory partners.
Sorry, I meant the vulnerability board. I mean, in the treatment.
Yeah.
Sorry, that's
right. Okay. So last week before last actually, I was invited to attend the Police Vulnerable Adults Board to come and talk about the work of the Safeguarding Adults Board, and that for me is evidence that we're reaching out, and because for the police, safeguarding children is much, it has greater clarification, because safeguarding children is very black and white. It's you know, if you're under 18, you're a child. It's not so with safeguarding adults and people's capacity to make unwise decisions, and sometimes to commit criminal acts if it's in the remit of the police. So we have to spend a lot of time making sure we have the right people around the table to determine what intervention is best. And I'm looking forward to going in January to the board, the Police Vulnerable Adults Board, to talk about this annual report, but also to talk in general about safeguarding. Does that?
Yeah, just so it is just made up of the police. So
that's police. That's a police board. Yeah.
Okay. Thank you. That was.
We ask to note the report, which we so do, and now we move on to the Better Care Fund. And thank you very much.
Okay, thank you. So just a quick kind of update. So you have the usual report and the template in the reports pack. So just bringing the template to you today to seek your endorsement of the template that we submitted under delegated authority on the 11th of November. Just by way of a couple of headlines from the report. So the template will be familiar to previous ones. The Q2 template is the same format as Q1. So just kind of the headlines for that are: we continue to be measured on our performance against emergency admissions, discharge delays and residential admissions. We're on track for 2 out of 3 of those metrics, with discharge delays remaining a challenge. But I think we've probably covered that in quite a bit of detail within the future care report. So we have our assurances in place that we've got actions in line to address that moving through the rest of the financial year. The financial position is on track. So within the template, we haven't needed to report any changes, so we're online as we expected to spend the BCF money at the beginning of the year. So it's just a case of please asking the board to endorse the Q2 template, so we can confirm that back to NHSE.
Thoughts and questions? Then we're happy to support. Anybody against? You are very supportive.
Thank you.
Very appreciative. Huge document. And I'm really glad that I had it. Thank you very much. Which brings us on to the community pharmacy, I believe.
Yep.
Thank you. Who is leading it?
Fiona, she's online.
Fiona's online.
Hi, good afternoon, everyone. I'm Fiona Arnold. I'm the Community Pharmacy Clinical Lead for Dorset, and I sit within NHS Dorset ICB. I believe that in previous meetings there's been some discussions around some sort of issues and queries around community pharmacy in Dorset. So I put together a very short report which contains some information on workforce and what we're doing to address sustainability of workforce within community pharmacy. Also, there was some information in there on pharmacy closures, temporary closures of pharmacies and interruption to patient services across Dorset, and then also some information on how we're doing with delivering pharmacy services, and particularly these are the additional clinical services that community pharmacies are commissioned to deliver, as opposed to the sort of standard essential dispensing service. So I don't know how you'd like me to approach, if there's particular questions, or if you'd like me to go through in more detail some of the things that I've highlighted in the report that I've submitted.
Do you want to go through your points first?
Yeah.
And then we've got some probably responses that we'd like to make.
Okay, that's fine. So looking at workforce, obviously we are aware in Dorset that we have gaps in workforce across all sectors of pharmacy within Dorset. We have a Dorset Pharmacy Workforce Faculty, which is hosted by Dorset Healthcare. We've recently done an optioneering event, which has obviously used data to help us pull out objectives of what we need to focus on in order to support all sectors of pharmacy and recruitment in Dorset. So specifically to community pharmacy, we have a work stream which is looking at the legacy workforce. So we are looking at how we can support every community pharmacist to become an independent prescriber, to be able to offer those extended clinical services, and also more likely to keep those pharmacists working within that sector. We've also done quite a lot of work on increasing the amount of trainee pharmacist places that involve community pharmacy, and also then retaining those trainees once they're qualified to work within Dorset to again support the sector and to be able to provide that through flow of workforce. If we look at other roles within community pharmacy, we've got pharmacy technicians. So we have quite a strong pharmacy technician trainee programme in Dorset, which is done sort of under an apprenticeship. And again, we work really hard to ensure that people that are coming onto that training get placed across sectors, which include community pharmacy. And again, that helps to increase the sort of recruitment into that sector and provide that ongoing workforce as and when needed. We also have a focus on the rest of the support staff for community pharmacy and what we can do to develop and encourage people to remain in that and have a fulfilling career in those support roles in community pharmacy. We're really also supportive of portfolio careers, so looking at all of those pharmacy professionals, and potentially a lot of people work across all sectors, which again has helped us to retain some of that workforce within community pharmacy if they're able to do some of the other work in some of the other sectors. And we're continuing to do that work, and we've seen certainly some increase in the figures and retention so far, which is positive. We always have a challenge in Dorset, as other counties do, where there is not a school of pharmacy feeding us as such. So you know, that's why we have to do this ongoing work to encourage pharmacists to train and then remain in Dorset to be able to support those running of those services. In terms of if we look at what we would deem to be temporary closures across Dorset in terms of pharmacy, so I'm sure all of you are aware that over the sort of recent 6 months, one sort of year, there has been an increase across the whole of the southwest in the amount of temporary closures reported within community pharmacies. Some of this is due to the financial sustainability of the sector, and it's not bespoke to the southwest. There has been an increase nationally in the amount of sort of temporary closures that we are seeing. We have in the southwest quite a strict temporary closure policy, so that enables us to, I guess, for lack of better words, sort of take action against the pharmacies if they don't follow the proper procedure for ensuring continuity of patient care when they have a temporary closure and not following the correct reporting procedure. So we have that in place. We also have other regulatory levers that we pull and are pursuing in order to address those contractors that are causing significant gaps in pharmaceutical access to services for Dorset residents. And all of that is managed both by the ICB but supported by the Southwest Commissioning Hub, which is where all the regulatory meetings sit and are held at Southwest level, and any decisions are made on that. We also locally have stood up a community pharmacy assurance group, which enables us to draw from people. So we have invited people from across the system to join that group, appropriate members, and that is where we will bring any local issues that we have and look at the next steps we might need to make in order to maintain or reinstate pharmaceutical services in areas where we have had issues or lack of that due to pharmacy closures. I then included some information on how we're doing with pharmacy clinical services. So these are nationally commissioned services that sit above the normal dispensing that pharmacies do. So they include the oral contraception service, the hypertension case finding service, and the pharmacy first service. So from what I've put in the report, you can see that we've got a good number of our contractors that are signed up to deliver that. So we have a reasonable coverage of that within Dorset. And there's been some high numbers of consultations and patients seen under those services so far. But again, there's capacity to do more. And obviously we want to support that left shift of activity and open up that access to people accessing that care at neighbourhood and community level. So to support that, we have sort of system meetings with Community Pharmacy Dorset, with 111, with sort of GP Alliance, which obviously represents the GP practices within Dorset, and we look at what we can do to increase use of those services. There's sort of two-way feedback in terms of assurance so that we can pick up any individual issues with contractors delivering those services, and just really look at how we can best support patients to get access to those things within Dorset. And then at a sort of more PCN level, we put on quarterly meetings for community pharmacies and GP practices that enable them to come together and discuss how those services are going at a more local level and how they can work with one another and collaborate to support that patient care within their individual PCNs. That was a summary of what I've put in my report. I'm happy to take any questions.
Thank you. I appreciate that your dream is the same as our dream, in that everybody has access to a pharmacy in their community with reasonable access, with consistent hours and quality service. But I think the reality that we're facing in many of our rural areas, but also in some of the urban ones, is that that is not necessarily the case. So can I ask you just to reflect on what are the blockages that stops a pharmacy from operating or closes one down, and how can we help you to overcome that?
Okay, so some of the barriers are the current financial climate and how the national contract is commissioned. Obviously, there has been recently some debate in Parliament about gaps in potentially regulations and levers that we're able to do to address that. So I think that is being looked at nationally, and I think there is probably limited things that we can do locally. I would say one thing we can do locally is if we get to a point where a contract is permanently closed or has their license removed, that we can, as a system, act quickly to ensure there is a supplementary statement issued in the P&A, and that we can work collaboratively to ensure that we put everything in place possible to enable another contractor where it's appropriate to be able to put in an application and fill that void if that is required. So I think that's something we can definitely do locally, and that's partly why we've set up the Community Pharmacy Assurance Group to provide that space for us to be able to do that when the time comes. I think the ongoing issues that we've had recently and that have been in the press recently have highlighted that the national sort of regulations and governance were not set up for these sorts of conditions. So if I've worked in community pharmacy a long time, if I go back sort of 10 years or so, we were never in these positions where to have a contract, a community pharmacy contract, was not financially viable. It was, if you ran your business properly and you provided good patient care, you would generally make a profit and you'd be able to keep the lights on. But in the last sort of 10 years, with the sort of real cuts that we've seen in investment of the sector, that hasn't been the case. And what we're now in a situation is that the regulations that we have, which essentially were set up to protect the network, don't allow us to probably act as swiftly as we would like to, now that we've been faced with these situations. But there's been a recent letter to all MPs from Neil Kinnock, and he has highlighted those things that we've all been sort of escalating upwards. And I think there is a review going on nationally quite urgently about potentially what changes need to be made to those regulations going forward.
I have a few more questions, but does any other people think so?
So I think part of this conversation came because at the last meeting we discussed the pharmaceutical needs assessment, and we talked about the fact that that's set up to control market entry, new pharmacies coming in, as Fiona said, into the market. What it doesn't really helpfully allow us to do is actually invite, consider that quality aspect and think about that in the round. We had highlighted particular issues about the pharmacy workforce, and obviously those are being addressed. The fragility of the market we're aware of, and I think that point about the assurance group and being able to quickly come back with a supplementary statement, that's something that this group needs to be aware of, that we need to be able to do that so that we can then quickly respond to any changes in the market that are coming down the line. So yeah, and I'm in that community pharmacy assurance group as well.
Keep on asking. We live in the world of Amazon and direct delivery to the door. Is the model of the traditional village pharmacy outdated? Do we need to change it, or does it just need to be given the strength to adapt?
So we do, so within the community pharmacy contracts, we obviously have bricks and mortar pharmacies, which is what you're sort of referring to in terms of the local village or community pharmacy. And then we also have distance selling pharmacies, which have their place. So, you know, in terms of if you go to a distance selling pharmacy, you can obviously get your medication delivered to your door, and that's part of their standard contract. But as we're looking to expand the amount of clinical services that community pharmacies are delivering, and certainly utilise the independent prescribing qualifications that community pharmacies have, some of those services obviously are required and have a need to be delivered face to face. So I believe it's a combination of those things. The other thing that has been supported nationally, and we've had some independent community pharmacies already sort of say that that's what they're going to do and come to us with an application, is to use a hub and spoke model. So that is whereby they move out some of their dispensing business to a hub where it gets dispensed, to allow them to concentrate on those clinical services, which supports their incomes and supports their sustainability moving forward. So it's a little bit of a chicken and egg situation, because until they get the increased income, they can't invest in sort of the things they need to deliver those services at a higher level. But certainly that is what we are working at locally, to get as much clinical services income into our pharmacies to sustain our network locally.
I appreciate that pharmacists are effectively in competition with some of the traditional stuff that would now come through Amazon and whatever. And forgive my ignorance, but does the council offer any incentives to people to set up pharmacies within communities, or reductions in business rates or rent or whatever, or are they regarded as independent businesses?
So they're regarded as completely independent businesses. So they fund everything. So they have a contract with the NHS to deliver pharmaceutical services, but they don't get any other sorts of funding. There is a small amount of money that's given under the pharmacy access scheme for pharmacies that dispense under a certain amount, but the issue with that is it's a set pot of money, and the more pharmacies that access that, it just gets less, and it's not really significant enough to make a significant difference to the business viability of a pharmacy. And there's no sort of resilience funding or anything like that to prop up community pharmacies.
Claire.
Yeah, thanks, Steve. Yeah, thanks, Fiona. I appreciate you're doing an incredibly difficult job here. So the paper obviously talks in generalities, and I suppose that's, you know, we shouldn't be talking about particular localities and particular pharmacies, you know, in this forum. But I suppose I just wanted some reassurance that where you're able to help, that there is targeting of at parts of Dorset where there is a particular need, really. Yeah, that's all.
So to give some assurance, we are aware of where we've got more significant problems in terms of patient provision due to temporary closures, etc. And we are offering some targeted support in those areas, and we are doing everything we can regulatory wise to move the situation forward in those areas. So I guess that's the sort of best assurance I can offer you. We are having quite in-depth discussions and sort of action planning around those certain areas, but obviously, as you said, I can't, you know, it wouldn't be appropriate for me to discuss the detail of that in this meeting.
Absolutely, thank you. That's all I needed to hear, really. Thanks.
Louise?
Thanks, Chair. I suppose you mentioning online pharmacies made me think about the pharmacy report that Healthwatch did last year to inform the pharmaceutical needs assessment. And in that, the proportion of people who told us that they used online pharmacies, they had very positive things to say about them. And actually, one of our recommendations was to make people more aware of how to access and how to use online pharmacies. So I just wondered whether there was any planned comms coming out from NHS Dorset to kind of let people know that they can use online pharmacies. And from what people had told us, they had very positive things to say about them.
Yeah, we've already done that, Louise, where we've had specifically where we've had specific challenges to access. We've done our comms team have done a sort of package of information for patients, and certain surgeries have displayed that on their websites, etc. And then we've connected with any sort of digital care coordinators to support people to be able to make the changes to their nominations to support that access. So we have, I guess, you know, being honest, we've got that slight gap where people aren't digitally enabled. It's giving that information and getting that information out to people that aren't digitally enabled is obviously something that is a challenge. But we are, where we've had specific issues, we've worked really closely with the surgeries to try and get that information out, and some members of our team have even supported with the actual sort of changing of supporting people to change their nominations who maybe aren't digitally enabled in those sort of situations. And actually the comms that Dorset ICB have done have been shared across the South West to support other systems to be able to do that as well.
Thanks, Fiona. Obviously, anything we can do to help get that message out, we'd be happy to. And like you say, it's having a mix of options for people, isn't it? So that people who can use online are able to access it, hopefully freeing up some space for the people who need a face-to-face help.
Thank you, Louise.
Thank you. Rachel.
Hi, Fiona. It's Rachel Partridge, Deputy Director of Public Health. I just wanted to take the opportunity to reflect about the workings of the Health and Wellbeing Board and recognise that this paper that you've brought and supported us with today, thank you so much, because this was generated out of quite a technical discussion around the pharmaceutical needs assessment, which we touched on earlier. But it clearly is an item that generated a lot of interest, enthusiasm, discussion from the board of the role of community pharmacists and that absolute support for our communities and ensuring that we've got good coverage to good quality services, providing really important access to care and support that supports health and wellbeing. So that spirit of integration, and this being a space where an issue, a topic, a gap, a challenge, a concern is raised through the discussion and the work of the board, and then your papers really and your presentation in particular to allow us to have that discussion, recognising needs to be at a higher level, but knowing that the detail is going on rather, feels like a good example of you know the difference that we can make, and some of the suggestions that are coming up as ways that members of the board and the constituent organisations can work to rally and support key pieces of work. And we've already had the session on future care, and this feels like another good example of that, you know, really making it real for the residents of Dorset. So that was a long way of saying thank you, but also as a reflection of some of the things that we can get around and galvanise through the health and wellbeing.
Yeah, and we have some amazing examples of contractors that are delivering, you know, extended and amazing clinical services to their communities. It's just that we do have a little bit of a resilience issue at the moment in certain areas, but yeah, we absolutely, as you said, want to get that quality of service and access in all our local communities, which is what we're aiming to do.
Thank you, Jill.
First of all, thank you very much for the report. It was really, really interesting. I'm just sort of mulling over how Dorset Council can actually help. And one of the things you mentioned was that Dorset doesn't have a school of pharmacy. At the moment, we're looking at setting up an allied health professional university in Dorset, and I wonder whether pharmacy could be something that could be considered as part of that. It was just a sort of thought how we could, where the blockers were and what we could do about blockers. The other thing that you've mentioned is about bricks and mortar, basically, buildings, whether there's anything we could do within that, within rents and leases and that sort of thing. I think the point I'm trying to get across is come and talk to us If there's
Okay.
a pharmacy wanting to set up that the NHS hasn't got a building in the area, we may be able to help. Obviously, yeah, sort of depending on what we've got in the area. The other thing I'm always very aware of, there's this misconception that pharmacists are well paid and have no issues with accommodation. From that point of view, I think our housing could possibly help a little. I'm not going to make any promises because it's on an individual basis, but I'm very well aware that somebody like a pharmacist in other areas would probably be recognised as a key worker, and perhaps we ought to do a bit more work around health professionals within our housing. Just building on a comment when I was chair of scrutiny, where we were looking at dentists, and dentists don't come to Dorset because they can't afford to live here. And these people are perceived as being reasonably well off, reasonably well paid. When it comes to living in an area like this, it's extremely difficult. So I think what I'm just saying, just excuse the ramble, but what I'm just thinking is if there's anything we can do, come to us and we'll see what we can do.
That would be great, and I think certainly some of the things you've mentioned, if I can link you, and I will update the chair of the pharmacy workforce faculty, because that's probably links more closely with the work that they specifically do. And certainly you're absolutely correct, we do one of the challenges is the cost of living in Dorset, and especially if you're a newly qualified or trainee pharmacist, and also the lack or the challenges of public transport, shall we say, as well, in terms of recruiting people in is also something that is highlighted as a challenge. So yeah, and all of those things, and also estates as well, is something that we often do struggle with. So absolutely, thank you very much.
Thank you very much for that. Sam.
So Sam Paul, Corporate Director for Commission and Improvement at Dorset Council. Fairly scary actually, Jill, because I was messaging the officer who is engaging with Health Science University in the background, just to say I think this is a good opportunity to have a conversation with you, Fiona, about how we might join up some of the dots around that school and look at that expansion in terms of the pharmaceutical stuff. So Fiona, I've passed on your details to the relevant officer, and it will be helpful therefore, I think, to have a conversation outside of here. But there is a possibility there, definitely.
What?
I just wondered, particularly in light of what you were saying about the need kind of to scale up the business in order to do more clinical services, in order to make them more financially sustainable, whether there was something around the Shared Prosperity Fund or the Rural England Prosperity Fund, because this is about innovation, business, more employment, and also, of course, making that last pharmacist in the village more sustainable. I don't know whether that's something that can go from here, from Pharmacist Direct.
Fantastic, thank you very much.
Thank you.
Thank you, Fiona. We are on your side. We appreciate that these are challenging times, but we appreciate that none of us are delivering yet within the communities the way that we would want to. And that there's also this thing that we only ever hear about the bad news, don't we? We never hear about the 99% that's really great. We only ever hear about the 1% that goes wrong. So we look forward to working with you closer in the coming months and years, and that we can really develop something that fits our geography, fits our demographics, and fits our health needs across Dorset. Thank you very much indeed.
That's great. Thank you all very much. Thank you.
I think that brings us to the end of this section of the meeting, George. Am I correct?
Yeah.
There's no exempt business.
Nope.
Anything else I have to say at this point?
No, but the
Other than
people
thank you.
online, would you like to stay online at the end of the meeting?
That's great. So thank you all very much for this section one of the meeting.